you. We'll try it again. Hello and welcome. I'm Joanne Pelton, and I'm the nurse manager for orthopedics at Spectrum Health. And Spectrum Health is has a legacy of excellence in orthopedics. Whoops, a little bit more. Okay, there we go. And Spectrum Health is recognized by U.S. News and World Report. We were recently named the only high-performing hospital in orthopedics in West Michigan, and our Center for Joint Replacement is one of the nation's leading providers of hip and knee replacements. It's also the only program in West Michigan that's recognized for quality and excellence for disease-specific certification in joint replacement surgery by the Joint Commission, which is the nation's leading healthcare accreditation program. We wanted to also, this seminar is being webcast, so we want to also welcome our webcast viewers out there. I wanted to mention that there's evaluation forms on the table. We'd really appreciate you filling those out. You can leave them at the table or turn them in at the end. And also, there's a little card on your table. It's a little question card. And we ask that you fill that out with questions. And you can hold them up when you have a question, and we'll collect those, and we'll read them at the end. And also, we do have a scheduler here today that will help with scheduling appointments or consults. Today, you're going to hear Dr. Adeoye discuss treatment options for hip pain. And following his talk, you'll hear Corey Snyder, who is a board-certified orthopedic physical therapist who works closely with Dr. Adeoye, and he'll show you several exercises, stretches, and strengthening tips that you can use to treat hip pain at home. Dr. Adeoye is an orthopedic surgeon with Spectrum Health Medical Group who specializes in sports medicine and arthroscopic procedures. He earned his medical degree from the University of California, San Francisco, and completed his orthopedic surgery residency at Yale University New Haven Hospital. Dr. Adeoye is fellowship trained in sports medicine and arthroscopic procedures at Stanford University Hospital in California, where he served as an assistant team physician for the Stanford football athletic program and athletic programs, as well as the San Francisco 49ers. He went on to complete a second fellowship in hip arthroscopy and preservation at the Hospital for Special Surgery in New York, and which is the nation's leading orthopedic and hip preservation program. His clinical interest includes sports, hip injuries, and hip pain in younger adults. Please join us in welcoming Dr. Adeoye.
Thank you. Grab the clicker here. Thank you. I'm glad that you're here this evening, and a lovely evening to be stuck inside, so we'll try to make things quick so you'll enjoy the rest of your evening. Dr. Adeoye, and we'll talk about treatment options for hip pain. So this is the agenda. We'll talk a little bit about the hip anatomy, hip pain, and evaluation, so what I look at.
Am I the only one that's having a hard time hearing?
You can? Can we turn up the... a little bit closer? Is that better? Okay. So we also talk about the hip at risk, hip impingement, sports-related hip issues, and also treatment options and outcomes of our treatments. So hip anatomy in general, it's a ball and socket joint for the most part. There's various structures around the hip joint, muscles, tendons. The labrum, which you hear about labral tears a lot, and then there's a cartilage. Pointer. So here's the cartilage here. The labrum is on the edge here, and then we'll talk a little bit about that, some capsule, and then the bone, the ball, and the socket. So the hip joint is a very deep structure covered in layers of skin, fat, muscle, nerves, and blood vessels. So true hip joints are usually described as groin pain, groin pull, a fork in my groin, pain in the front of my hip, but deep, I can't seem to get to it, deep, sharp pain that I can't seem to get to. So, there's a lot of things around the hip that can hurt, and this is part of the things that I try to evaluate in the office. So one of the things I'll ask is, so how did this happen? How long have you had the pain? Where is the pain? Is there different types of pain? Usually we'll have patients have, when I sit or do some activities, I have one kind of pain. When I lay down on one side, I have a different kind of pain. And we try to sort that out in the office. What things make it worse? Standing, sitting, walking, sports, any specific hip movements? And then is there any catching, clicking? Is that catching, clicking painful? And where do you think it is? And I try to get you to tell me about what symptoms you're feeling. I think that's very important to know. And then previous surgery. So any arthroscopic surgery, any osteotomies, which are procedures that people usually do when they're kids, and back surgeries. Have you had physical therapy? Did that help? Did that not help? So hip preservation is really a field that we're trying to identify sources of hip pain and pathology. We're trying to identify the hip at risk. Prior to hip replacements, there was a lot of interest as to why we get hip arthritis, and a lot of interest as to why we have hip pain. And once hip replacements came into fruition, and this is probably one of the best surgeries that we do, some of that interest died down a little bit, and we'll sort of talk about where the limitations are with that specific procedure. But in identifying the hip at risk, I'm trying to figure out where we're going to intervene to relieve pain and symptoms, preserve joint space and cartilage surfaces, and also restore a high level of function. So again, while there are many causes of hip pain, there are some hip abnormalities that can lead to hip impingement. These abnormalities are usually how the hip has developed from childhood. I hear that a lot. Was there something that caused my hip to develop this way? And the answer is usually no. A certain population of people will have these hip morphologies that will predispose them to hip impingement. However, some of these abnormalities may result in early development of arthritis, and this is really one of the areas that I try to focus on with my practice. So what's the issue? And so this slide sort of tells us a little bit about what we're dealing with. So I'll stand on this side. So if you have no to mild arthritis and you're sort of in this age group and your hip doesn't hurt, you're lucky. You just go on with life and everything is good. If your hip does hurt during this age range, then we look at hip replacements. And again, as I said, this is one of the best surgeries that we do in orthopedics. It's one of the most reliable surgeries that we do in orthopedics. And most patients that have the procedure done, their first statement is, I wish I had done it earlier. So it's really one of the things that is going to remain one of the staples of our treatments for hip pain, especially in older adults. But as we come down the age range, if you're young and you have significant arthritis, there's really very limited options out there for treating that hip pain, which is why we're now trying to target the group in the hip at risk. So younger adults with hip pain that have mild to no arthritis, that have this hip morphologist that will put them into this category, which is what? So we're trying to keep them going along and hopefully hit this category, or, if need be, hit that category, but at the appropriate age. So, hip impingement occurs when the hip joint does not have the motion needed for daily or sporting activities. This is not it. I think we'll all agree that that's a lot more than you need. So, types of hip impingement, and this is a little bit simplistic, but it sort of gets the point across. Again, the hip is a ball and socket joint. This is a normal hip. It should be really a round ball from the front to the back. And in some patients, you have this bump here. And what this bump does is causes damage within the hip joint to the labrum and the cartilage. And also, some people, they have a little bit of an overcoverage of their socket, which is like having a wedge. And as you bring your hip up, you have the wedge digging in, and that also causes issues. Let's go back. The majority of patients have the patients that I see, young adults that I see, have a combination of both, and we try to get that sorted out in the clinic, and also try to see if they have any labral injuries. So labral tears. Labral tears are, as I mentioned earlier, a specialized cartilage around the hip joint. It actually forms more like it functions more as a gasket. It keeps the hip joint fluid in the joint, and also has a little bit of a cushioning effect as well as we bring our hip up. So it's actually one of the few things in the hip that has nerves around it, and this can be injured with either a specific injury or with just wear and tear and repetitive motions. One of the reasons why these hips eventually, like we said earlier, they developed when you're a child, so why do they hurt now? So as we play sports, run, do our daily activities, you can have wear and tear that causes tears in the labrum, and it's that labrum that tells you, okay, there might be something going on. And we use the MRIs now, which has greatly improved our abilities to diagnose these injuries. So can sports or activity, recreational sports, high school sports affect my hips? The answer is yes. So it's one of the studies that we did where I trained. We looked at all the sort of high school to college athletes that came by complaining of hip pain. And we try to see, well, which sports do they play the most? And, why aren't we seeing all athletes? So why do we see a certain specific athletes? So we looked at this, and the number one sports in both male and females is soccer. I'm sure you've probably heard a little bit about knee injuries in soccer as well, but soccer is number one, hockey, football, lacrosse sports, so like lacrosse and track. What most of those sports have in common is they require a high degree of hip rotation, and that can get you into trouble, especially as our younger athletes get bigger, faster, stronger. They play one sport year-round. I think we're beginning to see a phenomenon of increased sports injuries in general, but now we're beginning to see more of it in the hip. And hip is quite a durable joint, so when we see young people complain of hip pain, then we have to sort of evaluate it further and make sure that it's nothing concerning that we have to deal with. So non-surgical treatment, so this is usually the initial treatment. Laboratory studies have shown that you can actually have regeneration and healing of the labrum, except if there's a major bone deformity. And these major bone deformities are things that we can see with x-rays, we can see it with CAT scans, and these are things we can usually tell in the office. So we do a course of physical therapy, which you're going to hear about today. Anti-inflammatories, rest, activity modification, corticosteroid injections. So one of the things I tell some of our younger folks who like to go to the gym and do squats and lunges and things like that, I try to tell them to reduce that to 90 degrees and not do as much of those specific exercises, because those can get you in trouble. So those would be an example of an activity modification. It's not necessarily that you can't do it, you should just do less of it. So moderation. So arthroscopic surgery, which is a lot of what I do, this is sort of what this looks like when I go inside. This is the ball, this is the socket, this is the labrum here. This is actually the cartilage peeling off the hip, the socket aspect of the hip. And this is the labral tear. So this is sort of what we see, and this patient, I think, was in their 20s. And we can actually see cartilage injuries already. So we see the hip impingement, labral tears, and loose bodies. So candidates, patients with no or mild arthritis, they've exhausted non-operative options, persistent hip pain for 1 month. And then sometimes we'll do an injection if the source of the pain is not clear. We sort of numb up the hip, numb up the labrum, and we try to get a sense, did your pain go away? And for a majority of patients, that does give them relief. That actually both is therapeutic for them, takes away the pain, but it also tells me that it's something that I can go inside and take care of. And we also get the MRIs as well. So there's still some things, and we've been very diligent about hip dysplasia in our infants. We check it with in infants, pretty much every infant that is born in the United States now, we check for hip dysplasia. In Europe, they actually do ultrasounds in some countries in Europe, in every infant to make sure that they don't have dysplasia. So they actually have less adults with dysplastic dysplasia. But in the U.S. we still see that because our clinical exam is not perfect. So we still see some adults with dysplasia. And if they're significant enough, they still require sort of open procedures, and they're not sort of candidates for arthroscopic procedures. So this is what sort of a typical, this is the hip, head, foot. This is the area of the hip joint here. We do 1 centimeter incisions, 3 of them. We get into the hip joint, and we do all our work. Although it looks relatively small from the outside, I remind my patients we did do a lot of work, so we have to take it easy and go through our rehab facility, rehab program very diligently. Hopefully anyone is not queasy in here, but this is what the hip looks like. This is the labrum again. You can see that sort of red and angry. This is the bone ridge here causing the impingement. We go in there and we take that down. So this is one of my favorite. This is one of my sort of favorite surgeries. You can see this hip in the back here is round, and here is essentially square. This is sort of square pegs. This is one of the types of hip impingement that I talk about, and this shape can be very destructive to the hip. So we also look at that as well. And this is the area that causes the cartilage to start peeling when you bring your hip up. So that's one of the things that we look at as well. So this is what a labral repair looks like. We put anchors in. We put sutures around the labrum. This is the labrum here. This is the labral tear. And we tie it down and we repair it. And that eventually heals. The sutures will absorb. We use partially absorbable sutures. But the anchors are usually a form of plastic that stay, but they're 1.4 millimeter anchors, so they're very tiny. Again, so surgery is a lot of science and part art, and these surgeries really enabled me to find the artist in myself. So again, you can see a square hip here, and we try to contour it to be round, just like the other side. So this is the same hip. And you can see that big bump there, and we try to contour it down. So this is the same. This is that patient that I showed you with the square hip. Again, we contour it down to match the other side. So this is what a lot of the surgery sort of entails, is reshaping the bone to help give longevity to that hip. So outcomes after surgery, the vast majority of patients significantly improve and return to a high level of activity. However, it does involve a dedicated rehab program. I tell patients, even though it's an arthroscopic procedure, There is a lot of healing that needs to happen of the tissues around the hip. And the rehab process is very similar to, having an ACL injury, for a knee ligament injury, for instance, that we've probably heard a lot about. So it's about 2 to 3 weeks in crutches and a brace, and then gradual and controlled return to activities. And then for athletes, it's usually about return to sport in about 3 to 4 months. All right, that's it for me. We'll have questions later, I guess. Or questions now, later. And Corey is the therapist that works, physical therapist that works with me. I lucked out. He came up from the University of Michigan, and he's excellent, and he's been a great asset to my practice, and I send a lot of my patients to him.
You guys hear me okay? Good? Okay. Again, my name's Corey Snyder, physical therapist. I'm very fortunate to be here tonight and working with such a great surgeon. And I'm glad that you are all here to listen and try to learn a little bit about how to preserve your hips. So we'll get to, whoops. There we go. So my agenda here is we're going to talk about what type of exercise is best for your hip, how you strengthen your hip, how you stretch your hip, and then what is involved if you do undergo hip impingement surgery. So first question I always get to with my patients is who exercises? So just as a show of hands in the room, anybody exercise on a daily basis? 3 times a week? Twice a week? Okay, yeah, good. So we have active people out there, and that's good. We want you to stay active. It helps your longevity, it helps your mobility, it helps your general health and fitness. So anytime somebody comes into the office, I usually ask them, are you an experienced or novice exerciser? Do you have pain that affects your exercise? What are your goals for your exercise? Are you training for a certain race or a certain activity? As well, are you an athlete? And if you are an athlete, what level do you compete? Are you high school, college, recreational, weekend golfer, recreational tennis, singles, doubles? What are the requirements of that sport? And then whether you're in season or out of season will affect your physical therapy as well as any medical decisions we're making as well. So generally, if somebody's experienced or novice, the first thing with an experienced athlete, what I'm going to do is a biomechanical evaluation. And generally what I mean by that is I'm going to watch you move. So I'm going to look at how you squat. I'm going to look at how you lunge. I'm going to look at how you twist and bend. And then we're going to determine whether those type of motions are causing a problem at your hip joint. People who are novice exercisers, generally, if you're getting started in a fitness program, I always recommend you be screened by your primary physician first prior to coming into therapy, just to see if there are any other medical issues that you need to take care of prior to engaging in a lot of exercise. The next question then, does pain affect your exercise? And this is common for my clinic. I usually don't see people in the clinic unless they're having pain. Occasionally I'll have athletes that come in just with maybe a sensation or something that doesn't feel right at their hip, but generally people are coming into the office to see myself or Dr. Adeoye with pain. If you have no pain, then there's no problem, right? We can continue on with our exercise, but if there is pain, the modifications that we typically want to make or to consider is maybe going from high impact exercise, so let's say you're a runner, so changing from running maybe to cycling, or running to an elliptical trainer, or swimming, and then also maybe even it's something as simple as changing the duration or frequency of an exercise. So if we have walkers in here, people that like to walk on a daily basis, you're having some hip pain, you're walking that 3 miles and you've done that for every day for 6-7 years, well, maybe we need to look at that distance and that frequency or your pace and see if we can make a simple adjustment that helps your pain. So again, getting back to your goals for exercise, are you training for a marathon? Is football season coming up? Are you doing weight training just to generally stay fit. And again, hip preservation and trying to take care of your hip to avoid that end-stage hip replacement, the important things are to keep generally fit. And the American College of Sports Medicine recommends to do cardiovascular exercise 3 to 5 days a week of at least 30 minutes. And interestingly, that 30 minutes can be broken up. It doesn't necessarily have to be all in one block, but that's oftentimes the best way to get your heart rate to a good level for weight loss, as well as doing resistance training. So that can be body weight style training, or it could be weight training. And then, of course, if you're an athlete, when we're doing exercise, we want to think very sport specific. So you want to think about doing exercises that are specific to your sport, whether that be golf or baseball or football. So generally, you're not going to ask a gymnast to do a lot of low impact swimming type exercises, right? You want them to train in the environment that they work. Same thing with a runner. We want to have them run or do running style exercises to train the same muscles that they need to compete in their sport. So then the question is, how do you strengthen your hip? And this slide here, what we're trying to show is if we think of our hip as a clock. So we have 12 o'clock on top, 6 o'clock down below, 9 and 3, right? We have certain muscles that are more active around that clock. So as you're moving your leg, certain muscles engage at a certain time and then turn on and off to help help you move. So you want to think about all the sides of your hip. So the flexors are the muscles in the front, okay? The glutes, the ones in the back, all right? Abductors are the ones on the outer thigh, and the adductors are the ones on the inner thigh. So we'll go over those terms kind of repetitively as we go through these exercises. So when you strengthen your hip, you want to pick the best exercises. And through research, what we do in physical therapy and rehab is we try to identify what has the highest electromyographic activity, which is a big word, so we call it EMG for short. And that basically identifies what muscle or which part of the muscle has the most activity in it, okay, or which gives you the biggest bang for your buck. So there's 4 main exercises that have been shown through research to have the highest activity around the hip. And in thinking about all 4 sides of your hip, I've picked the 4 that have the highest activity. So the quadruped hip extension, okay, which is this nice looking model here, was doing this exercise. So you start in a kneeling position, and then from that position, you're going to extend one leg back. Okay, and as you extend that leg back, it activates the muscles on the back of the hip. Okay. A single leg bridge. All right, this is a challenging exercise, but also one that's pretty easy for everybody to do. Most people can get into this position, starting on your back with your knees bent, lifting your hips up in the air. Whoops, go back one here. Lifting your hips up in the air and then extending a leg. So you're basically balancing on one leg. And that activates a lot of muscle, again, in the glutes as well as your abductors. A clamshell exercise, okay? This is an exercise where you lay on your side with your knees bent, and you're going to keep your feet together and then separate your knees apart. So this particular exercise strengthens the lateral side or the abductors of the hip. And then the final exercise is a step up. So this is the starting position. So you've got a step. This could be any step in your house or a curb out on the sidewalk, and then stepping up onto the block with your knee up in a high position. Okay, and that activates really all the muscles on the hip. So the glutes, the abductors, adductors, and your flexors. So flexibility is also an issue for the hip as well. So it's not just about strengthening. We want to have good mobility and flexibility. And when you think about getting involved in flexibility for your body in general, there's really whole body and isolated stretching. So whole body stretching, or activities like yoga or Tai Chi, where you can stretch multiple muscle groups all at the same time. In my clinic, generally, I'll incorporate some of those activities, but I'll also get into some isolated stretching as well. So where I'm trying to just isolate one muscle at a time. So when I stretch your glutes, or when you stretch the muscles on the back of the hip, getting into this type of position where you're crossing one leg over the other and pulling them towards your chest, and that will stretch the posterior aspect of your hip. The flexors, this is one that stretches the front of the hip, so you get into this kind of half kneeling position and try to shift your hips forward. So once you're in this half kneeling position, you're trying to move your hips or pelvis forward to stretch the front of the hip. Your abductors, so these are the muscles on the side of the hip. If you cross one leg over the other and then push the hips to the side, or push one hip to the side, it will stretch the outside of the hip, so this area. And then the adductors, which are the inner thigh muscles, okay, getting into kind of a split stance position or a split leg position, and then leaning one direction will stretch the inner half of the hip. So if you are good with these exercises and you stay strong and stay flexible, generally, most people can avoid these type of extensive surgeries. But as Dr. Adeoye mentioned, increasingly, especially in athletes, we're seeing these problems creep up more and more. And if conservative treatment were to fail, getting into surgery and then the recovery is very important. So the rehab process is very strict. There are several phases to it. The immediate rehab phase is generally about a month, 4 weeks. So as Dr. Adeoye mentioned, you're going to be on crutches for a couple of weeks, and then there's going to be a period of time where you're just trying to basically learn to walk the right way again. And then an intermediate phase where we start to work on range of motion and some of those flexibility exercises that I showed earlier. And then the endurance and strength phase is where we start getting into body weight strengthening exercises, as well as doing exercises with weights, resistance training, balance training, that type of thing. And then if you are an athlete, the return to sport phase is often the most challenging, because you've been very, very patient through this first 3 months, and now you're in a phase where you can't quite do everything the way you used to, but your brain still feels that way. And so we have to kind of work through some challenges and some different exercises to try to get you back where you want to be. So in my opinion, the big keys for recovery from arthroscopy are the skill of the surgeon, finding the right person, somebody that's familiar with the procedure, knows what he's doing, he or she's doing, and can get you the result you want. And then your compliance with rehab. So if you're going to go through this type of procedure, you have to be committed to the rehab. It can't be something that you just say, well, I'm going to do it part-time. So, and then the good communication between the patient, between the therapist, and between the doctor is a key. So making sure everybody's on the same page. And that's why I definitely came to Spectrum, because it's a team atmosphere here, working with myself, Dr. Adeoye, Matt, athletic trainer, and the whole staff in orthopedics. So questions?
All right. Well, thank you very much, Corey. We do have some questions for Dr. Adeoye, and then Diane is also going to collect questions that you can ask Corey as well. So here comes Dr. Adeoye. You can go up there if you'd like.
Oh, it's a hot sit?
Yes.
All right.
Okay. Our first question is, please speak to hip bursitis symptoms and treatment.
Yeah, so the general type of hip bursitis is one that is on the outside of your hip, just right, but that bone that we can press. When people say hip bursitis, that's really what they're referring to. There's a gel around that area that allows the tissues to slide. And when you're having some inflammation of that gel, you can get pain around that area. So that's really what bursitis is, and there are different things that we do in the office to try to calm down that inflammation, and they involve stretching exercises as well as injections, as well as stretching exercises, really to try to calm down inflammation. And once the inflammation is calmed down, then it takes a while before that comes back again, and that's usually a fairly good treatment for hip bursitis.
Okay. Another question, are there side effects of using glucosamine chondroitin in MSM? And the second part is, does supplemental calcium increase pain?
I'll take the first part first. There's not been any published, as well as research published, side effects of taking glucosamine. The issue with glucosamine is that we don't know who it works in, and we don't know how well it works. I mean, I think we've had anecdotal evidence in which patients come and tell us, that they've been taking glucosamine for a certain amount of months and they get relief from it. But in the percentage of which, we can say, okay, I can say with confidence that we should take glucosamine chondroitin, I don't think we've met that yet with that supplements. But I tell my patients that come in, if they want to give it a try, I mean, that's okay. The general thought is it takes about 2 to 3 months of taking it to get it, to see any if there's going to be any difference. The issue is most of us that take that, we take it with Aleve and Advil and other things, and it's really hard to figure out, is it the glucosamine that's working, or is it the anti-inflammatory that's working, so I think all that still needs to be teased out a little bit better. What was the second part of that?
Calcium, supplemental calcium, does it increase pain?
No, I mean, there's not been any sort of research studies as far as supplemental calcium increasing pain. Now, supplemental calcium is very helpful for our bone health, as well as to help with osteoporosis or sort of thinning of the bone as we age. But generally, within safe dosing, supplemental calcium is safe. Now, if we take too much of it, there are other medical issues that can occur from that, but that's not usually pain.
Okay, here's one for you, Corey. At 85, will physical therapy help? I have exercised every day for many years.
Oh, it's a broad question, but a good question. I think physical therapy can definitely help you. It's all about identifying your goals. So, first question I would ask is, what is your goal? Is it to be able to climb the stairs? Is it to be able to walk a mile? What do you need to be able to do? And then that's what, as a physical therapist, my primary job is to help you meet those goals. And we give it a try, see where we get.
And another question, why is pain severe at night when I want to sleep? No?
Is that for me or
Sounds
for
like a
him?
common theme.
Is that for me or for, I think pain can definitely vary. Pain can be something that changes during the times of the day and obviously at night. Our bodies generally don't like to be very sedentary. So when you get stuck in one position sleeping for many hours, that's oftentimes where, as a therapist, at least we hear our patients say, oh, it hurts when I lay on my right side and I try to sleep like that all night and I just can't do it. Well, sometimes it's simply changing positions. Sometimes it's doing certain exercises or stretches to let that tissue be more flexible so that you can lay in that type of position.
So, the only thing a couple of things I'll add to that. One is that it takes use and time for inflammation to build in the joint, and that can take hours over the day. So you wake up in the morning and you do everything that you need to do, and you come back home at night and your joint is hurting. So sometimes what I tell patients is to try to get ahead of it a little bit. So if you know that you're going to be doing a lot, that day. You take the anti-inflammatory before you start those activities so that you're not sort of at home at night when it's quiet and you're really focusing on the pain and notice that you're sort of not catching up to the pain. The other thing is side sleepers. I got a lot of questions with regard to folks that sleep on their side. And that also kind of ties in a little bit to that bursitis question that we talked about a little bit earlier. So, you can feel the bone right there. That's the area of the bursa. So if you have, inflammation of your bursa and you're sleeping on your side, you can have some, really significant issues falling asleep unless you sort of change positions. And I know patients sort of flip back and forth. The other issue is that bone also, I know we sort of talk about bursitis a lot, but two of the major hip muscles attach on that bone. So you can actually have tendinitis of that area, not just bursitis. So it's, so what I try to clarify is this just garden variety bursitis or is this tendinitis? And the treatment for either one of those is different. So so that's just one, a couple of things that I'll add to that.
All right, there are some questions about hip replacements, but Dr. Adeoye, shall we go on to the other ones too? We got lots of questions now. This person says, I had a knee replacement, now my hip hurts. When I walk, I know I should do more on the operated leg.
I stand more on the leg that was operated.
Oh,
And now I find when I walk let's say a quarter of a mile or further, my hip really hurts. And I observe that because this knee really needs to be done or something done to, I stand on the leg that was operated on because I don't have any pain. And so most of my weight is borne on the operated leg, and now my hip is saying, forget it. So what have I done, or what can I do to avoid this?
That's a good question. You want to
I think you've sort of told us a little bit about what's happening. You got a knee replacement, and that knee feels good. So that leg is sort of taking a lot of the work, your sort of daily activities there. And it's not uncommon to have arthritis in the hip as well as in the knee. Although you may have gone some X-rays and you may not show arthritis there. One of the things that we try to do, because you also mentioned that your other knee is hurting. Okay, so and Corey sort of plays a little bit into this, is to try to balance sort of how you use your legs. And I see this often, especially in my patients that have had surgery. So they're in crutches, they're using one leg, that hip that they're using all the time starts to hurt. And then they say, oh, okay, can we do something for that hip? And I say, wait a minute. Once you're off crutches and you've balanced out your gait, usually that pain goes away. And I suspect that some of it is, having to have you balance out your gait for you to use both of your legs equally. Now, if that entails dealing with the other knee, well, that's sort of more of a personal question, more of a personal issue. Right. Well, of course.
But yeah, I think that gets to a big part of it, and is specifically with physical therapy, is just trying to, we try to keep your body in balance. So, if you are overloading one side, then seeing how we could maybe better share that weight. Yeah, yeah. And sure. Well, I think it stands to reason that you might. So, and it's worth the try, and especially if you're trying to avoid a procedure or something like that, it would be well worth investigating that. So, yeah.
For either one of you, some folks wanted to know if there is a better bed to relieve pain, like a Sleep Number or a Tempur-Pedic.
Yeah, I mean, that is a really, I mean, it's a little bit of a, individual question. So, I talked a little bit about how people sleep. I'm a stomach sleeper. So, I like firm, hard beds. So, it's really, I mean, there is no single bed for anyone. So, I mean, that's just, what I have to add is you have to kind of, I'm kind of that obnoxious guy you see in the mattress store, testing out all of them. That's me, because I'm a stomach sleeper. So, I think one of the things that you do have to see is, one, try to get a sense of how you sleep or how your spouse sleeps, because you guys might have different ways of sleeping, and that may affect the choice of bed that you get. And really try out as many of them as you can.
I would tend to concur with that. I don't prescribe to one particular bed or recommend something to patients specifically, but I see a lot of people that run too, and people ask about shoes all the time. So it's shoes and beds are the common questions I get, and it's always what is comfortable, and it's really, you do have to go spend some time testing those out. So as far as the mattress goes.
For the doctor, what causes cracking or popping of the joints, and is it harmful?
So of which joint? Hip?
Well, let's say hip.
So there are normal clicking that happen around the hip. There again, as we mentioned, there are different tendons around the hip that shift positions as you are moving your hip around, and those can be normal except if they hurt. So if the cracking or the clicking is not associated with pain, then I usually ignore it. If it is associated with pain, then we can evaluate it further. But pain is really the guiding principles to sort of the clicking or catching or things that happen around the joint. So if it's not painful, it's fine. If it is, then we have to look at it further.
Okay. And here's another question. Will an MRI differentiate a hip issue versus a lumbar or nerve impingement? And how often do you see both or either one?
Yeah, so that's a very good question. I see both quite often. In the MRI of the hip and the MRI of the spine are both great diagnostic tools, but there are things that we can see on either MRI that may not be the source of the patient's pain. And that's really where we talked a little bit earlier about doing the injection in the hip. That's really where I use that. Because if I have a patient that looks like they might have both back and hip pain, then what I try to do is I try to numb up the hip. So we put an anesthetic into the hip joint, essentially numb the entire hip up, and ask them, do you feel any different? If the answer is yes, 50% of my pain is gone, 70% of my pain is gone, then I know at least that there's some hip issue within that. But if we do the injection in the hip and it doesn't change the hip symptoms, and I'm fairly confident that the issue is not the hip joint, and then we have to look at things like the back and the nerves. So that's really how we try to tease that out in the office, and that's why we have one of my partners and I would do ultrasound-guided injections in the office to try to sort those back hip issues apart.
Okay. Here is a question about hip dysplasia. What are some non-invasive options for a young adult runner who is struggling with congenital hip dysplasia?
Want me to start with that?
That is the young adult and the congenital hip dysplasia part is things that we see. I think it's the runner part that can get a little bit difficult. I mean, we know that running itself, especially sort of excessive running, however you want to describe that, increases joint load. And part of the issue with hip dysplasia is that you edge load your socket. So if you sort of, you essentially have a linear area, in your hip that you're sort of edge loading. So now you have running, and you add that to that issue, and it creates some, a lot of problems. And and with those patients, I really do have to counsel them. Although runners don't like to hear it, but we have to talk a lot about cross training, especially if they want to keep running at any level at some point in the future. Then we really have to talk about cross training and doing other types of activities in addition to running.
Yeah, I would tend to concur with that as well. Activity modification from a therapy standpoint would be the first change. Not that you want to give up running, but if you hope to run, especially across the lifespan, trying to get into other forms of exercise as well. And then really trying to assess whether, because there are bony changes with a dysplastic hip that create some of the problems that we've discussed, then trying to see if there's a muscular component too. Are your muscles in balance? And sometimes I've had runners that have had some improvements with that, just by trying to balance out their hip, but generally there's still some challenges and some modification needed in the activity.
And just to add to a little bit of the cross training is also core and hip strengthening. I see a lot of runners who are in general very fit, but running is a sort of a linear sport, and even though you're sort of fit, you can actually be weak in other areas, which is one of the things we assess as well. I see a lot of runners that actually have very weak core and hip muscles, which is not unusual. It's a little bit of a difficult conversation in the office where you say, well, you're actually weak in your hip. And they're like, I run 10 miles a day. I'm like, yeah, I know you do. But, we need to cross-train a little bit, and we need to focus on your core and hip strength, especially in the dysplastic, because you will need that hip muscle strength for secondary stabilization of your hip joint.
And here's a question about arthritis. Does arthritis in your hip can arthritis in your hip make your legs weak? And can arthritis in your hip cause thigh pain?
The second answer is yes. The answer to the second question is yes.
So
You can
can
have
cause
sort of
thigh pain.
referred pain down the thigh with hip arthritis. The first question about arthritis making your hip weak is a little bit more of a complicated one, because once our joints start hurting, the body tends to shut down, especially muscles around that particular joint. Essentially, your body is telling you, I don't want you to use that. And over time, you also use less of that joint. And over time, the leg becomes weaker. So it's not a direct link that you have arthritis in that joint that causes the weakness. It is the compensation that happens after you start having the pain from the arthritis that leads to weakness in the leg.
And for Corey, are there any exercises that you feel are best for bursitis?
So definitely with bursitis, one of the first areas that I target from a strengthening standpoint are the glutes. So things like the bridging exercise that's on there, as well as the hip extension exercise when you're on all fours. Stretching-wise, it's, as Dr. Adeoye mentioned, we do want to work on some flexibility, but I find too that stretching can be painful for bursitis as well. So you really need to get it evaluated and tease out whether it's a tendonitis or a bursitis. If it's truly bursitis, stretching the hip abductors, so doing kind of a crossover type stretch is sometimes helpful. But it also depends on how much pain you're having and that type of thing as well.
And one of the things that I like to do in the office, especially when someone comes in significant pain, is to do a one-time corticosteroid injection to that area, and then a week later have them start therapy. Because I find that if you sort of start therapy in a painful state, usually you get discouraged very quickly, especially with the stretching and things like that. So I try to deal with the pain and the inflammation first, and then start therapy a week later. And I found that patients are usually more successful going through that physical therapy course after that.
Okay, and here's a yes or no, hopefully. Do you ever operate on both hips at the same time, or is that not an option?
That would be a no. The reason being is the rehab that is involved, especially in the first 6 weeks, require that you use one leg more than the other until you normalize your gait. And we're waiting for tissues to heal, and if you do both hips at once, it's really hard to make you to protect either side. So we're putting equal weight on both sides, and that can get you into a little bit of trouble. So I try to do stage them. The minimum I'll do is 6 weeks between both sides, but I generally find that one side is more symptomatic, and once we sort of done that side, it's actually a minority of patients, even though they're feeling great from their surgery, once they've sort of made up with all those compensations and all those issues with Corey and therapy, there's actually a minority of patients that come back for the other side. So I try to do one side and and say, hey, why don't we go through this side and see at the end of the day if the other side is still hurting, then we'll deal with it. Unless there's some major bony issues there that we have to deal with, but I wouldn't do both at once. There's also increased complications from that as well. Meaning blood clots is the biggest one that we think about doing both sides at once, because you're not as mobile, and you tend to stay in bed a lot more, which is not good.
Okay, and one final question here. What causes the fork in the groin pain, kind of the stabbing pain, and does it eventually go away, or does it get worse?
So there's a couple of things in that area that can cause that pain. One is a labral tear can cause sort of that fork in the groin pain, especially if you bring your hip up and you engage the bone. So you can get those symptoms. To make matters a little bit more complicated is that right over on the other side of the capsule, right over that labrum, is a big tendon that goes around there as well, and that tendon snaps normally, and sometimes that snapping can be painful, and that can also cause, and it's one of the major hip flexors, so that can also cause sort of that groin pain. So it could be one of those two issues.
To what extent is hip bursitis affected by diet?
I'll have you tackle that one.
Not to my knowledge. So, but I would say, one thing that I notice in the clinic is good general fitness, healthy lifestyle. Affects a lot of joint pain, muscle pain, tendon pain. So if you're obese or inactive, the likelihood of those type of problems tends to increase, like other problems in the body too. So.
And for either of you, if for folks who have hip pain or hip bursitis, and sit a lot at work, have you found any products or aids that can help with hip pain?
So I'm a little measured in my response, because the word bursitis means many different things to many different people. If it is the sitting aspect that long car rides and things like that, you have pain with sitting for extended periods, then, generally, things that will open up that space. So you're sitting like this, and some people will find that they have to lean back when they ride in the car, or they have to stand up to sort of relieve that pain. So, I know there are different ergonomic type chairs now that you can sort of kneel, sit, that help with, some of those patients that have extended, pain with extended sitting. And I've had a few cyclers that have issues with that as well, especially if they cycle in the arrow position. So I tell them to modify their sitting position to sort of open up that space in order to help relieve some of their symptoms. But, again, I'm a little measured in my response because the word bursitis means a lot of different things. And, I sort of have to evaluate that further, I guess.
And it is just a tad after 8 o'clock. We want to be respectful of everybody's time, so we will wrap up. Corey and Dr. Adeoye have agreed to stay a bit longer if there are a few more questions that we didn't get to. We do want to remind you again, if you would please fill out your evaluation form. And we do have a representative from Dr. Adeoye's office, Matt, up here. If anybody would like to, leave their name and phone number, if you would like a call back for scheduling a more in-depth consultation with Dr. Adeoye, we are able to take your information and get back to you to make that happen. I did want to mention we did have a few questions specific to hip replacement, and although Dr. Adeoye does not do hip replacement, his specialty is really in basically trying to preserve your hips and do some of the interventions short of the replacement. He does have colleagues that work with him at the Spectrum Health Medical Group Orthopedics office who do those replacements. So if you are interested in speaking to one of those folks, we can help you get connected there as well. So thank you all for coming, and thank you, Dr. Adeoye, and thank you, Corey.
Thank you.